Yeah, so I'd like to introduce John Pihlaja, who is Training Director of the Helsinki Psychoterapiainstituutti. And I met John first at the European Brief Therapy Association conference in Poland, I think it was, some 9 years ago. And we hit it off immediately, and he invited me to speak to a group of students in Finland, in Helsinki, the following year, and I have been coming over since then. And one thing I was struck with in those early days of coming to Helsinki was that John was really starting off in 2 small offices in central Helsinki, and from then has moved to this vast office complex, which is now the base for the training institute, and he and his staff have now trained hundreds of therapists and psychologists in solution-focused brief therapy. So, John.
Well, it's my pleasure to introduce John Henden, who is a really important pioneer in developing solution-focused techniques. Now, solution-focused as an approach to many different areas of life, but particularly today, we're speaking of its applications in mental health and situations of mental distress. And it has a wide range of tools and techniques and approaches that are seemingly simple. Many of them are seemingly simple, but nonetheless do require practice to actually get them to work in live situations. Now, John Henden has been particularly gifted in applying these seemingly simple techniques to the most extreme situations of mental distress, applying apparently simple techniques to severe trauma recovery. And by severe trauma recovery, I do mean, for example, combat stress, and not just some little accident that happened the other day. And even working with the British Armed Forces in developing those techniques.
Indeed.
But for our topic today, particularly, is extremes of depression. So when a person is so depressed that he is seriously considering killing himself. And John Henden has applied solution-focused methods to even these most extreme situations of depression.
If I could just interject there, John, it may not be depression, it may be an extreme crisis situation that the person finds themselves in, and this can come on very suddenly too, when people become actively suicidal because of the crises or crisis that confronts them.
Okay, so how did you get interested in suicide, of all topics, in the first place?
The alarming thing I found in my professional career, which spans some 40 years, is that many professionals shy away from suicide as well. And they would rather treat someone's sleep disturbance, their anxiety or their depression, rather than address suicide as the primary problem that's confronting them. So yes, it started in the early 90s. I was privileged to be at a training event facilitated by Steve DeShazer, one of the co-founders of the approach. And on the train on the way back, after the 2-day workshop, I could see the potential for applying solution-focused principles, beliefs, tools and techniques to the challenging areas of mental health.
You were working in the mental health area?
Yes, I was at the time, and had been for over 20 years before I became aware of solution-focused brief therapy. So on the way back on the train, I was thinking, yes, this can be applied to a whole range of different situations. And a short time afterwards, I was working in a community mental health centre, and we had some suicidal clients there. So asking solution-focused questions, applying the techniques, we saved lives. They would recover very quickly. And then...
So right off it was that easy to learn?
Yes, it was. And then I, along with others, found we were designing advanced solution-focused techniques, or specialized solution-focused techniques specifically for those who are suicidal. And these had an amazing power. And anyway, a short while after that, I started running teaching events and then workshops, and that worked up to 1 day, then 2-day workshops, training therapists, psychologists, lay workers, military welfare workers, in fact the whole range. People coming to my workshops were, some of them were qualified and some of them were totally unqualified. They were merely mental health workers or volunteers working in organizations where people who were suicidal were presenting.
At some point you got an itch to write about this.
Yes, I did. And yes, I remember at one workshop towards the end, a couple of the participants said, John, it's all very well teaching us about this in these workshops and you've got some handouts. How about putting it in a book? So I thought, no pressure. And it was, so I thought maybe one day, but I knew what a daunting prospect that sounded, put it in a book. You know, there are hundreds of hours required in to write a book. And anyway, a short while after that, I lost a cousin to suicide. And
it became all that more personal.
It did. And that, coupled with my earlier lived experience of suicide, I thought, no, my own personal story. And one thing that struck me at the funeral, I noticed amongst the crowd, was my cousin's family doctor. He'd known the family for years. And he looked somewhat embarrassed. A combination of that with disbelief and dismay as to how one of his patients should take their lives after he'd prescribed the medication. How come they hadn't recovered? Well, I know from my experience, my 40-year experience of working in mental health services, that medication is not treatment. It's simply symptom alleviation. And my cousin's difficulties were not addressed, and he was not referred for talking treatments, and the expression on the GP's face was one of the biggest motivators to start writing.
In Finland, depression is a very common reason for people to lose their ability to work and become pensioned.
Yeah.
And it seems that 80% of those become pensioned without having had access to talking treatment at all.
Yes, I find that totally unacceptable. I mean, to a certain extent this happens at home in the UK. It's not that they're not offered treatment. Sometimes it's described as care. They don't use the T word. Treatment is avoided as a word. They talk about care. But we know, those of us who've been working in mental health and psychological services for decades, it's effective talking treatments that people need in order to get their health back, to recover, and then to get their lives back such that they can begin to thrive. And in too many countries of the world, people with mental health problems are deprived of that effective service, and that really needs to change.
So at some point you started, so the motivation was big enough to actually start writing a book, which, as you mentioned, is a tremendous amount of work. what would you say was your main driving motivation to take that on?
Well, I think those two factors I've mentioned earlier, plus the fact that, oh, incidentally, one thing I should mention here is I was working in a community mental health centre at the time of developing these solution-focused tools for working with the suicidal, and we had a wonderful service that we provided for the doctors of the area I worked, the catchment area, and this was a lunchtime crisis intervention slot, and doctors who had patients in their surgery in the morning at 8:30 who were expressing suicidal thinking could refer them to the crisis slot and be seen that day within 4 hours. That was a wonderful service.
Wow.
And during that time, the time I was involved with this service, we had no suicides, and yet we had some highly suicidal people week by week that we saw in this crisis slot. Now, at the same time, in other parts of the psychiatric system, there were frequent suicides in either outpatient departments, outpatient lists, I should say, daycare facilities, and in the inpatient unit. And we asked ourselves the question, how come we were having no suicides?
Because you could see a difference in numbers even.
We could see a marked difference in numbers.
Not just anecdotes.
No.
My client, that was so brilliant,
No.
I cured him.
That's right.
This is numbers.
This was numbers, and we had 0 each year in the service, and yet in other parts of the service they were having 4 or 5 a year. Now, during my time working in formal mental health services in hospitals and psychiatric units, I saw about 20 suicides, sadly, amongst patients in our care. And it was what we were not doing that was resulting in those high numbers.
That's in hindsight.
In hindsight, yes. Excuse me. And at the time, it's interesting this actually, because what the teams do, what we did then, and this still happens, I'm told from colleagues who still work in these settings, is that after a suicide, the team gets together and they come out with things like, well, they were pretty determined to do it anyway, so it's merely a matter of time. Or we've been providing all this range of services, and it's something of a mark of ingratitude that they've decided to hop off the planet as they've done. And other reasons that people came out with to somehow to either justify or excuse, or both.
And blame the client.
And blame the client, yes.
Your motivation came from actually seeing results. And you started to put that into a book.
Yes.
And that apparently it was quite a success.
Yes, the book, when it came out, was a terrific success. Worldwide, I had feedback from therapists and from psychologists and from other practitioners and lay people as well. This was really heartening, because that's what I wanted to achieve. I wanted it to be a textbook and a reference book, if you like, for both professionals and lay people who are involved in mental health.
Right, and the name of the book, unsurprisingly, was?
Preventing Suicide, the Solution-Focused Approach.
So you mentioned lay people, which implies two things. It implies that the book itself would be readable.
Yes, one thing I was determined here, John, to achieve was to write a textbook which was jargon-free. Having done a first degree in psychology and been steeped in jargon during those days, I wanted a book which was accessible And so if there could be 2 small words of 4 letters and 5 letters to replace a word of 13 letters, I would find them.
There's also a second assumption behind that, and your assumption is that lay people can also make a difference, given even some relatively simple perspectives and tools.
Indeed, and I mean, just on that, it's interesting actually, 2 things here. Firstly, my secretary at the time, her husband, who is, I would say, as a classic layman, he has no psychological knowledge or background. In fact, he's a chemist, if anything, professionally. And he collared me one day. He said, "John, just to let you know," he said, "I picked up your book just to see where you had acknowledged Alison and all the typing she'd done." And he said, "Before I knew where I was halfway through it in the afternoon." I thought, fantastic. That's what I want to achieve. And the other thing I'd say about that is that, as far as lay people are concerned, telephone helplines, crisis lines, are often staffed by people who've got good listening skills and are able to have that rapport over the phone with troubled callers, and but they don't necessarily have any professional qualifications. And I had good feedback from them that it's been really useful.
Right. So what perhaps would be what do you think would be the most powerful tool or perspective provided in your...
Well, as I said earlier, a lot of the solution-focused techniques, the basic ones, we've adjusted them, we've given them a little tweak to apply to people who are suicidal. But there are a few specialist solution-focused techniques, and one of these is the graveside or crematorium scenario. And that stands above the others as one of the most powerful lifesavers.
That sounds pretty dramatic. Isn't it dangerous to talk about stuff like that?
Yeah, this is an interesting point. When I was a trainee mental health worker many years ago, we were told to avoid anything like any talk like that. And I remember a tutor saying to me, "Whatever you do, don't mention the means of suicide with the patients. You might give them ideas." Well, research has completely debunked that point of view, and the research says the opposite, that by talking about it honestly and openly with clients, they value that. And the other thing about that, and I mentioned this in the book in several places, is that it's as if clients have a sort of a radar up here, and they can detect if we're thinking about something and we're deliberately not touching on the subject. They will pick that up, and they'll pick it up as dishonesty in that relationship. So the graveside scenario is taking the individual to beyond the point where they've taken their life. They're either in their grave, in the trench there, or they're on the slab at the crematorium, and we ask them to describe who is there. And as if their spirit is hovering about 3 meters above, looking down. And initially, it's interesting actually, they have difficulty saying anyone is there at all. But when pushed, they will come out with relatives, friends, workmates, etc. And the skill then, from the practitioner's point of view, is to ask them what each of those 4 would say about how the deceased person could have done it differently in order to survive and get through their difficulties and build their own solutions that didn't involve taking their lives.
So you're actually taking the person to a completely different level or a completely different perspective
Yes.
on his own situation.
Yes.
In your book, of course, you address how to do it in such a way that is and has been proved to be effective rather than dangerous.
That's absolutely right. And with this question, I encourage therapists to always ask permission of the client to ask a rather unusual question. And in all my years of asking clients permission, it goes something like this: can I ask you a rather unusual question? I've yet to have someone say, no, you can't, because people are too curious.
True.
And
even a suicidal person will find curiosity in himself at that point.
They will.
So that first question is actually already part of the technique.
It is.
You're already kindling something which wasn't there a moment before.
Yes, that's right. And that's interesting, the point you make about curiosity, because in my experience, clients who are suicidal, who are coming for help, are curious as to what the worker, whether they're lay or professional, is going to come up with in the discussion that might be helpful to them.
Right. And they have that hope, and they prove that they have that hope by being there.
Yes, indeed.
In front of you. And that's the living proof of their will to live.
Absolutely. And that touches on another subject. Much research has been done about people who have taken their lives, and a shockingly large number have consulted with a practitioner within the previous month. So what was happening there? They came to the worker, they came to the service with hope, and they went away hopeless. And it's they're staggeringly high percentages, which questions the quality of those services. And so one of my missions, if you like, in teaching the solution-focused approach to suicide prevention is to address that issue.
Well, your book was an almost instant success, and it probably would have gone on being a success, but you decided to update that.
Yes, indeed.
A revised second edition with 5 new chapters. So you took on more writing work for yourself. So what drove you?
Well, partly publisher pressure. My commissioning editor at Wiley Blackwell, who has been very supportive throughout this project, way back in 2006, I think, when I first spoke with him. He said, well, of course, John, it's getting, it's selling well, but the years are going by, we really need a second edition. And I managed to delay it about 3 years, but eventually I realized I had to do it. So the second edition is very much updated with the research, newer research papers quoted, and we've got 5 new chapters.
So which of those stands out for you as being personally significant?
Of the 5 new chapters? I think
for your mission, which is very
personal. Okay, yes it is. And I think, just to list the 5, first of all, we mentioned blaming earlier. There's a chapter on how we, the collective we within mental health services can blame the deceased person. Secondly, there's one on, I've got a chapter from Alice Cole King, who is a psychiatrist in the UK, a liaison psychiatrist. She's also clinical director of Connecting with People, which one of their main aims is to mitigate suicide in health services. And she phoned me out of the blue one day, just after the first edition had been published, and it seemed that she was having similar ideas to me as about how we could be more effective in services. So this is like a chapter from her, which is terrific. I'm delighted. She talks about, I realise I'm not answering your question directly here, but she talks about compassion in working with people who are suicidal, and that is very, very close to my concept of deep empathy. So that's the second one. Then the third one is working with working on the phone, on telephone helplines. And a fourth is solution-focused suicide prevention initiatives around the world. So, because this has been going international for the last 10 years or so. And so I've listed the countries of the world where there are solution-focused suicide prevention services, and mentioned other data about those countries. And then the final chapter is on zero suicide. And this is flagging up zero suicide as a healthcare initiative. And so I've mentioned the key movers and shakers in the zero suicide movement, like David W. Covington, Mike Hogan and Ed Coffey. And this grew out of the Detroit Depression Service, where they developed a protocol for working with people coming in off the street with depression, and found that by sticking to these guidelines, really getting alongside people, they could reduce suicide to zero. And they achieved it. Wow. And out of this movement, well, it's become a worldwide movement now, to an international declaration. I think it's something like 27 countries have signed up to this now, including Finland and the UK. And part of it is that no one should die of despair and loneliness while they're in our care. That's the zero suicide aim, if you like.
That's that's a challenge to us.
It is a challenge, and one thing to say about it, it's a no blame approach. So if someone
so we don't have to blame the professionals.
No,
or the client.
No, but we take each case and look what happened. What could we have done differently? We're not blaming the client. We're not blaming their key worker or their clinician. We're saying what happened. How did we let this person slip through the net? So we in the service can learn for other clients. So it is that very much no blame culture.
Right.
But
it's a learning culture.
It's a learning culture, but zero suicide is the objective.